form the head and neck vessels join up at the truncus arteriosus part of the primitive heart. And with this, we have the heart ready to be septated. Okay, so this is the heart before septation begins. The atria, then the cardiac cushion, the ventricles, the conotruncal tissue, and then the pharyngeal arches, which form the head and neck vessels. So septation of the atria, we said, begins from the roof of it, septates downwards into the endocardial cushion here. We talked about the fact that we initially have a septum premium formed, gets perforated, a foramen ovale is formed, and then a septum secundum forms as a flap valve to cover up the rest of the septum to create our atrial septum. We also said that at the same time, the roof, the floor of the ventricular chamber forms an interventricular septum, which grows up toward the same endocardial cushion to septate the ventricle. And then we said that laterally, the mesenchymal cells on either side of the tube invaginate towards the same endocardial cushion to divide the heart into the upper chambers and the lower chambers and form the tricuspid valve and the mitral valve tissue. So that completes the septation of the atria and the ventricle. Then there's the septation of the truncus arteriosus in a spiral manner to form the pulmonary artery, which is anterior and to the left, and the aorta, which is posterior to the right. Okay, and with that completes the septation of the ventricles and the truncus arteriosus into the aorta and the pulmonary artery. Subsequently, we said that the pharyngeal arches, which were connected to the truncus arteriosus, then undergo a series of regressions and evolutions to form the head and neck vessels. And these head and neck vessels join up with the newly formed aorta to complete the arch of the aorta and the head and neck vessels. And in each step of the way, we looked at the errors that may occur in the process. So the next structure that we're going to look at is the systemic venous return. So we've looked at the arterial connection. So we're going to look at the veins. We are going to look at the veins. So the most important structures that come together to the venous return is the sinus venosus, which we already saw in the cardiac tube. Okay, and then this venosus connects to a series of precursor veins around the primitive heart, which include the cardinal veins, the vitelline veins, and the umbilical veins. These three sets of veins in the early fetus are what drains blood from the placenta, the yolk sac, and as well as the anterior and posterior aspects of the fetus. And these structures also undergo processes of regression and remodeling, combined in various ways to form the SVC, the IVC, and the coronary sinus. Here, so if you go back to this image, you find that the primitive atria is connected to the sinus venosus. So we'll just focus on that image alone here. So we have the primitive atrium connected to the sinus venosus. So connected to these sinus venosus are what I said earlier on, the cardinal veins, the umbilical vein, and the vitelline vein. The umbilical vein drains the placenta, the vitelline vein, the yolk sac, and the cardinal vein, which is the CV here, drains the rest of the fetus. So these connect to the sinus venosus. Okay, they connect to the sinus venosus. And in pairs, they are paired structures. So whatever structures you see here are mirror image over here. So left anterior cardinal vein, you have a right anterior cardinal vein. Left posterior cardinal vein, you have a left posterior cardinal vein. Left umbilical vein, you have a right umbilical vein. Left vitelline vein, and then the left But if you focus on the right structures here, a number of them regress. Okay, but more importantly, the right anterior cardinal vein ends up forming the superior vena cava. Okay, and then the inferior vena cava will be formed by the right vitelline vein. The rest of the venous structures there evolve. So we see the transformation of these venous structures into the SVC and then the final IVC here. All the other veins regress subsequently. The right posterior cardinal vein also forms the azygos vein, which we know is an important structure that drains blood into the superior vena cava, as we can see over here. So, in short, when it comes to the systemic venous return, the main focus is the sinus venosus, the cardinal veins, umbilical veins, and the vitelline veins. And together they end up forming the SVC, the IVC, and then the azygos vein. The left anterior cardinal vein, which is a mirror image of the right anterior cardinal vein, originally forms the left SVC. So as this one forms the right SVC, this forms the left SVC. But ultimately, the left SVC regresses, and that is why we don't normally have a left SVC. But if this process does not occur, that is when we end up with the persistent left SVC. Okay, so the final structure SVC, IVC, azygos vein connected to the left innominate. The sinus venosus itself does not regress, but ends up forming the coronary sinus at the posterior aspect of the heart. And we know that the coronary sinus drains the venous drainage of the heart posterior to the left atrium, drains veins that empty into the right atrium. So at the end of this process, we have the coronary sinus draining into the right atrium, IVC draining into the right atrium, the SVC draining into the right atrium, and a azygos vein joining up to the SVC and ultimately also emptying into the right atrium. So that, in effect, concludes the systemic venous. So what are some of the problems that may arise? So we have an uninterrupted IVC, which we see in left isomerism, so or heterotaxy, where you have interruption of the IVC. It doesn't form well and doesn't connect directly to the right atrium. But then what you have is that you have an azygos continuity, as you can see. Essentially, the IVC and the azygos, which should be draining in the lower segments of the body. If the right vitelline vein does not form the IVC properly and there's an interruption, then the azygos vein will have to do the job of draining the lower portions of the body. And the other problem that may also happen is when you have a persistent less FZC. And this also ties in with anomalous pulmonary venous drainages as well. The left SV is especially important when it comes to cardiothoracic surgery because of cannulations of the vena cava. The surgeon must know about a persistent left SVC so that they can cannulate it as well as the right SVC. Okay. So, all right. So I'll just continue then to the pulmonary veins. So the pulmonary veins occur at the foregut. Okay, they occur at the foregut, and they arise from plexus of pulmonary veins that join together to form a common pulmonary vein. And this common pulmonary vein incorporates into the left atrium as a single vein, but eventually it divides into four other veins which connect to both the left and the right lungs, returning venous supply from them into the left atrium. This process occurs at the same time as the atrial septation and the evolution of the sinus venosus. because the atrial septum must be formed in such a way that this common pulmonary vein is committed to the left atrium and not to the right atrium. Because if that process does not occur well, then that is when you have varying forms of the total anomalous pulmonary venous drainage or return. So I'll show the image here. So this is the rudimentary or the earliest form of the trachea and the bronchus that will lead to the formation of our lungs. Okay. Now you have a plexus of veins that is formed in the foregut just above the area of the heart. And this plexus of veins take their connections from the cardinal veins, the umbilical veins that we discussed previously in the formation of the systemic venous return. So what then happens is that the plexus of veins, the pulmonary component of it, join together to form a common cardinal vein. Okay, or a common, sorry, not a common cardinal vein, but a common pulmonary vein, as you can see here. Now, this common pulmonary vein joins to the left atrium, as you can see here. And at the same time, the atrial septum is being formed. And this process is so important so that if this atrial septum was to form in this direction, then you will see that the common pulmonary vein would have been draining into the right atrium. So the connection here must occur almost around the same time as the septation of the right atrium. Once this connection is completed, the rest of the plexus of veins evolute, they disappear, okay, to go and form the systemic veins as I described previously. Okay. The remnant of the plexus of veins then connect to the development of the lungs, which is also occurring at the same time. So this is to ensure that the moment the lungs are formed, there's already this connection between those lungs and the common pulmonary vein. So already venous returns from the lungs are established before the lungs are fully formed. Once the lungs are fully formed, almost at the same time, the common pulmonary vein divides into 4 segments, 2 to the right, 2 to the left, and thereby establishing your left upper pulmonary vein, your left lower pulmonary vein, your right upper pulmonary vein, and your your right upper pulmonary vein, your right lower pulmonary vein, your left upper pulmonary vein, and your left lower pulmonary vein. Okay. So in short, this is how your pulmonary veins are formed. The key clinical things are that they are formed simultaneously as the lungs are being formed and as the atrium is being septated, just to ensure that there's proper pulmonary venous return to the left atrium. So obviously, if this process does not occur properly, then we end up with variant forms of total anomalous pulmonary venous drainage or partial anomalous pulmonary venous drainage. And I'll explain how that can occur. Okay. All right. So with that, we'll conclude the basic embryology of the heart. We've looked at the formation, early formation, primitive tube formation, looping of the heart, connection to the aortic arches or the pharyngeal arches, septation of the atria, the ventricles, the truncles, and the formation of the head and neck vessels from the pharyngeal arches, the formation of the systemic venous system, which involve the sinus venosus, as well as the cardinal, the cardinal, the ventral and the umbilical veins. And then finally, we've looked at the formation of the pulmonary veins that arise from a plexus of veins around the portion of the development of the lungs. And this plexus of veins form a common pulmonary vein that connects to the left atrium and at the same time connects to the developing lungs. And this occurs at the same time as the atria is being septated. Okay, so if there are any questions in the next 1 minute, we can take it before I move to the rest of the presentation. Hello?
Hello, Dr. Adela. You can go ahead, please.
Okay. So I just quickly move, stop sharing, then go to the next presentation. Okay. So I'm sure you can hear my co-presenter in the background. Just excuse us. All right. So I'm going to look at the left to right heart shunt lesions in a very simple and fast, way through this format. For we know that these lesions include an atrial septal defect or a patent foraminal valley, atrioventricular septal defect, ventricular septal defect, and aortopulmonary window, and finally a patent ductus arteriosus. Go to the atrial septal defect. Overall, it
I'm
constitutes.
sorry, Dr. Adela, please, are you sharing any slide?
Am I?
Are you sharing a slide? Have you shared a slide?
Yes, but it's not showing.
Okay, I can see, but sorry, let me. Gordon, can you see?
No,
Are his slides
no,
visible?
please.
Not yet, sir.
Oh, not yet. I'm sorry. Let me just do this.
Okay, it's visible now.
Now, okay, all right.
Okay, so
So
please,
I
you can put the slideshow. Ah, perfect.
okay. So I look into the left, right, and I'll go through it and do some just quick introduction, symptoms, examination, ECG, chest X-ray, echocardiograph, cardiac cath, and treatment. So these are the lesions we are talking about. Like I said, we're going to focus on the first, the 1 and 3 today, and then we'll do the rest on a later day. Septal defect. We know that they constitute about 20 to 40% of all congenital heart defects in adulthood. But overall, they are about 10% of congenital heart defects. They are essentially a left to right heart at the atrial level, and it will lead to right atrial and right ventricular dilatation with increased pulmonary blood flow. The shunt or the extent of the shunt depends on the size of the defect. So you can have small, moderate to large defects. It also depends on the compliance of the ventricles, especially the right ventricle initially, and then also on the pulmonary vascular resistance and the systemic vascular resistance. So if the pulmonary vascular resistance remains lower than the systemic vascular resistance, then our left to right heart shunt lesion is established. But if along the line there's pulmonary hypertension and the pulmonary vascular resistance goes up and becomes more than a systemic vascular resistance, then we can end up with a reversal of the shunt. I've noticed that the shunt is greatest in the late ventricular systole and early diastole. So these are uh, areas where you will have a drop in the pressures on the right side and a commensurate shunting of blood from the left to the right. Ultimately, the increased pulmonary blood flow leads to remodeling of the vasculature of the lungs, and that causes the increased pulmonary vascular resistance. So if it goes unchecked, the end game is that you end up with pulmonary hypertension, Eisenmenger syndrome, and varying degrees of atrial arrhythmias. This is the defect that we are in a simple form talking about. Okay, a defect in the atrial septum. We've looked at the embryology already. So blood flow in late ventricular systole or early diastole coming from the left atrium to the right atrium, mixing up with systemic veins, and then continuing up into the pulmonary vasculature. We also know that there are essentially about 4 or 5 common types, or as various literature may point out. So the secundum ASD, which is at the upper portion of the septum, the primum ASD, which is around the endocardial cushion, and if you remember from the embryology yesterday, are associated with cleft in the anterior mitral valve leaflets. Then we have the sinus venosus ASD, which are ASDs that occur either at the entry of the SVC into the right atrium or the entry of the SVC into the right atrium. Okay. And these are commonly associated with the total anomalous pulmonary venous connections or the partial anomalous. And then we have the coronary sinus ASD, which form around the area of the coronary sinus, usually with an unroofed coronary sinus. And these are usually associated with the persistent left SVC. And so I'm sure you can begin to appreciate some of the embryologies that we've spoken about already. The ASD being associated with the cleft, the sinus venosus ASD, and the coronary sinus, which I talked about not long ago, and its relationship with the left SVC as well. So ultimately, whenever you discover these various types of ASDs on your assessment on echo, you need to rule out these other associated lesions. So this is just an illustration of what I have said. SVC, IVC. So at the junction of the SVC to the right atrium, we have the superior sinus venosus. At the junction of the IVC to the right atrium, we have the inferior sinus venosus. At the upper part of the septum, this whole area is the septum, okay, which has been opened up. That will be the secundum ASD. Closer to the tricuspid valve, which is here, will be the premium ASD. And then around the area of the sinus, the coronary sinus, which empties into the right atrium, you have the coronary sinus defect. So the important genetic associations, which I mentioned yesterday as well, which arise from the signal transduction gene factors that control the coordination of all the embryogenesis. Okay, so yesterday I talked about the TBX5 gene, which is common in hot Oram syndrome. And so these are patients who have various forms of ASDs with limb abnormality, absent radii, either unilateral or bilateral. And it's usually inherited in an autosomal dominant form, even though you can have sporadic forms as well. Okay. Then EVC, Ellis Van Crefeld gene, EVC gene, which is also associated with the septum formation. And in addition, ends up with skeletal dysplasia as well. These are usually inherited as an autosomal recessive form. And then the NK 2.5 it's associated with familial ASDs. So if you have ASDs that are running through families, and usually will come with AV blocks, then usually this is the gene that is implicated. And then there's GATA4 as well, which is also involved in ASD. So essentially what this slide seeks to point out is that if you diagnose an atrial septal defect, there are a number of things you must look out for. You need to do an examination of the limbs. Okay, all the skeletal portions of the body must be examined because of these two syndromes. In addition, you have to look out for heart blocks as well. And know commonly we end up seeing a lot of first degree heart blocks, which is the natural progression with the dilating right atrium. But then, especially for port oram and then the EVCs, you can actually end up with complete heart blocks. Okay, and that's just because of the genetic makeup of the conducting tissue and the atrial septum. So what are some of the common complications that occur with ASDs, especially as you go into adulthood? Because a lot of time ASDs remain silent in the pediatric age group. They only begin to rear their hair after the third to fourth decade. Okay, so you end up with paradoxical embolisms and strokes, pulmonary hypertension, right-sided heart failure, and then importantly, atrial fibrillations and flutters, and then complete heart blocks. So if you look at the history, like I said, most will go undiagnosed for decades. Okay, but beyond the sixth decade, you definitely have symptoms, and the reason why you have definitive symptoms in around this time is that as we age, we know that our left ventricle begins to become less compliant. So your left ventricular and diastolic pressures begin to go up, and so which means that the pressures on your left side begin to even increase them more, and so your left to right heart becomes more. And so you have more blood going to your pulmonary arteries, and then you end up being a bit more symptomatic. In addition, if you look at the premium ASDs with the cleft and anterior mitral valve leaflets, they end up with mitral regurgitation, which also progressively gets worse as you get older. Okay, and so that naturally would would cause the symptoms to get worse. And then, of course, with passing years, the pulmonary artery vasculature undergoes progressive remodeling. So by the time you reach above your fourth decades, you already begin to have established pulmonary hypertension. And then finally, the atrial arrhythmias also get worse with age. Okay, so the combination of these factors, the left ventricular and diastolic pressures going up, the worsening mitral regurgitation for anterior mitral valve leaflets, the increasing remodeling of the pulmonary vasculature, and the worsening of the atrial arrhythmia ensure that certainly by the time you get to your fourth to sixth decade, you should be having symptoms of ASTs. So the common symptoms that you find as you get older are exertional dyspnea and recurrent chest infections. So recurrent chest infections from the plethoric lung fields, exertional dyspnea from the pulmonary hypertension and hypoxia, the palpitations from the atrial arrhythmias, and then the syncopal attacks. Of course, once you have atrial arrhythmias, your cardiac output is like will drop as well. From They may present for the first time with strokes from the paradoxal embolisms, and then with established pulmonary hypertension, they may end up coming with symptoms of right heart failure. Occasionally, too, they will just come to us because somebody had an incidental memo and abdominal heart sound during a routine assessment. Or it may also be that patients may be referred to you because of the familiar history of members of the family having atrial septal defect, which we have spoken about already. In terms of physical examination, you have normal examination, which is why they get missed. More often than not, and that's because some of the characteristic early changes in ASD, like the wide fixed split of the S2, are not characteristic features you hear in the pediatric age group because the heart rate of the children are relatively faster. And once you have such a relatively tachycardic heart, it's difficult to appreciate the split of the second heart sound. But as you get older and the right side of the heart begins to become volume overloaded, and ultimately pressure overloaded, then you have the RV heaps, the epigastrial pulsation, in keeping with right ventricular hypertrophy and dilatation, a palpable P2 from increasing blood flow across the pulmonary valves. And then when you auscultate, you may hear a split of the S1 because of the delayed closure of the tricuspid valve when a lot of blood is rushing across it, or a wide fixed split of the S2, which we know is it's a fixed exaggeration of the physiologic changes in the second heart sound in inspiration and expiration. Now, you may also hear a loud P2 in keeping with pulmonary hypertension, a mid-diastolic murmur at the left lower sternal border from the rush of blood across the tricuspid valve, an ejection systolic murmur from the rush of blood across the pulmonary valve. If this goes unchecked and you end up with Eisenmenger syndrome, then you end up having patients who are cynosed with digital clubbing. Okay. A lot of this ejection systolic murmur sometimes can be confused with ejection systolic murmur and pulmonary stenosis. But the difference is that you're not going to hear a mid-diastolic murmur more often than not in pulmonary stenosis, and you will not hear a wide flick split. What you hear will be a second heart sound in pulmonary stenosis. Chest X-ray, the main things that we see are usually a cardiomegaly, which is because of the dilatation of the right chambers, a prominent pulmonary artery from the increased pulmonary blood flow, a plethoric lung field, and less commonly, you may have left atrial dilatation from the MR that we see from the cleft and anterior mitral valve leaflet associated with the premium ASD. You may also have a dilated SVC on chest X-ray, which is because of the the sinus venosus ASD that you may have. So typically, as you can see in this heart, if you look at the cardiac silhouette, there's a bit of cardiomegaly, and then you can appreciate the SVC. You can see the right atrium also dilated here, rounded and marginally lifted up apex in keeping right ventricular dilatation, and a bit more prominent pulmonary vascular marking. And then when you do a lateral view, you can see that the anterior border of the heart almost reaches that of the sternum in keeping up the right ventricular dilatation. So ECG is also important. We know that generally you have a sinus rhythm, a right axis deviation because of the volume loading over there. A first degree heart block. You may have right atrial enlargement, right ventricular hypertrophy, and right bundle branch block. These will be commonly what you will see in significant shunt of an ASD. But there are the other findings that you must keep an eye on. A coronary sinus rhythm, okay, where we know that your P waves are usually inverted in like lead 3, okay, and that will be in keeping with sinus venosus ASD. So if you have features of ASD, you do your ECG and you have what looks like a coronary sinus rhythm, then it's most likely that even before you do your echo, your ASD is a sinus venosus ASD. If you do the ECG in a suspected ASD and is a left axis deviation, then it's likely to be a premium ASD as a component of the endocardial cushion defects because they show a left axis deviation. In pediatrics, we will say a superior axis deviation. Okay. Also, you have to look out for atrial tachyarrhythmia, either atrial flutter or atrial fibrillation on that ECG. I think last week we saw a 25-year old patient with clinical features of an ASD, both secondum and premium ASD, and he had really significant atrial tachyarrhythmia and needed to be on medication. And then with those that are associated with the Ellis Van Creveld, you see features of a complete heart block. And so there's a lot to be gained from an ECG of a patient with an ASD. So this would be a typical uh, one. So a sinus rhythm, a right axis deviation called lead 1 negative, and then AVF positive, right atrial dilatation, and the right ventricular hypertrophy, as we can see from the uh, significant R to S ratio in view 1. And then subsequently after the ECG, we'll go and do the echo. And the importance of the echo is to define the defect, the size, and the hemodynamic state of it, and also to define the associated lesion. So if we look at this is the 25-year-old I was talking about. We saw last week. He came to us from Sierra Leone. So in an apical fortune, but you can appreciate the superior defect here, which is the secondum ASD. And then this is where the endocardial cushion would have been. And so you can see the premium ASD defect as well. And that is confirmed on color flow, the flow from left to right. I know adults, you echo the heart upside down, but I'm sure you can orient yourself with what I'm showing. So the atria here and then the ventricles down. Sorry, let me just do this. Yes, sorry. I think I need to just go from Kesa. Okay. All right. Okay. Can you hear me?
Yes, the we can hear you.
All right. Okay. So then one of the associated lesions, which I hope you can see here, is where my pointer here is here. You can see the mitral regurgitation, the blue flow away. And this is because this patient, in addition, has a cleft in anterior mitral valve leaflet. So in just one view, the pickup for we can delineate the secondum ASD, premium ASD, common AV valve junction. There's a tiny ventricular component, but there's not much flow through it, and then a cleft in anterior mitral valve leaflet. okay, in an EST. So this is the kinds of information you can gather from the echo. Okay, so we'll move on. And then the role of cardiac catheterization in ASD is important, especially as in adult cardiology, to establish the shunt using your QPQS. And usually, if you have a QPQS that is more than 1.5, it means that it's a significant shunt and will require closure. And it's also important for pulmonary hypertension studies as well to assess reversibility when there are clinical features of pulmonary hypertension. And then as you get older, like I said, it's also important in assessing your left ventricular and diastolic pressures, and then also to assess your coronary arteries. And this information is crucial, especially when you are making a decision whether to close an ASD in a much older patient, because when your left ventricular and diastolic pressures are very high, then the atrial septal defect becomes a pop-off for the left side of the heart. If you go ahead and close that ASD, then you can imagine what begins to happen on your left side. You eventually will end up with left heart failure because your left ventricle is not compliant. There's all this volume of blood just rushing down from the left atrium to it, and it has no outlet for it. So in such patients, it becomes a contraindication for closing the atrial septal defect. So I remember, I mean, when I was in my training, we had, I think, about 56 or 70-year-old, and I mean the left ventricular and diastolic pressure was borderline. And so after we put the device in the cath lab, we noticed that the left ventricular and diastolic pressure had shot up significantly. But of course, you couldn't take out the device in that case. So we had to put guide wires to perforate the device that we had placed in there just to create, I mean, like a flow regulator, well, in this case, a permanent regulator, for the patient. So that's an important thing that needs to be done for adult ASD closure. Then, of course, you can also, during cath lab with your angio, delineate the anomalous veins because those can be difficult sometimes to see on echo. So I think last week we got another patient who came in just for an ASD, and then we noticed that the pulmonary veins were not connected properly. So we did the angio, and then you're able to delineate where the pulmonary veins are. And it turns out that it's an intracardiac, it's a cardiac TAPVC. Also in cardiac lab, you can do a device closure, and then forgive my spelling here. You can also do electrical ablation during the process for those that have some tachyarrhythmias that need attention or and are refractory to medication. So ultimately, the definitive treatment for ASD is based on the evidence of right heart volume overload and not on symptoms. Okay, because we know that naturally, even if they are not symptomatic now, they are likely to be symptomatic in a couple of years. So once there's evidence of volume overload, then it's time to close it. Uh, in childhood, we are not quick to close because some of the ASDs can close. So we usually leave it until, usually we'll try and say preschool, but sometimes even a bit older than that. Then in ASDs, in adults do not close. So we need to close them. And the closure can either be surgical plus repair of the associated lesions. So for instance, if you have a TAPVC with an ASD, you close the ASD and then you reconnect your pulmonary veins. Or we can do device closures. And the commonest devices that are used are the ampullator, septal occluders. Okay, but we must bear in mind that there are contraindications for closure, either both surgically or with device, especially when they are insignificant shunt, where your QPQ about is less than 0.7, severe pulmonary hypertension, which is not reversible. Or like I said, if you have significant uh, increased left ventricular and diastolic pressure. So post-closure, some of the things to consider is that even after surgery, you have a lifelong risk of atrial fibrillation and flutter. So they have to be followed up essentially for life. So before surgery, after surgery, ASD adult must be followed up for life because of this lifelong risk. And we've seen that happen in recent times. And a number of our patients are coming back. And so, and that's because during the surgery, I mean, you can either do direct closure with sutures by opposing the margins of the ASD, and that alone creates electrical focuses for arrhythmias to form. Okay, there's always a 6 month risk post surgical closure, okay, of ASDs, and that occurs until the patch that are used are epithelialized before the risk goes down. And ASDs are notorious for post-op pericardial effusions. When it comes to the device, like with most devices, the device can embolize. You can have post-implantation arrhythmias, thrombus formation. The device can erode or perforate the heart. I've seen that happen before, which is why we have to ensure that the margins of the ASDs are suitable for device closure. And then, of course, if the device does not sit well, you can always have residual shunts. Okay. So ultimately, there's always room for some medical treatment. So we can manage the atrial arrhythmia, which we did for our adult patient last week. It was started on bisoprolol, which was not working well enough. So it then was switched to amiodarone this week. You have to manage patients with severe pulmonary hypertension, especially if there's contraindication for surgery. So then they have to be on pulmonary hypertensive with reducing drugs as well. And then, like I indicated, there's a lifelong follow-up because of the risk of atrial tachyarrhythmias. There's always controversies about ASDs, especially in adulthood. The question is always, should all ASDs be closed irrespective of the size? And there are some school of thought that say close all of them because of the risk of paradoxical embolism. We never know where you're going to throw an embolism across it. Okay. Well, there are also those who feel that if the shunt is not significant, leave it because of the increasing left ventricular and diastolic pressure and the fact that it can become useful as the patient gets older. So those are debates that keep going. But now in Europe, most people will close PFOs because of paradoxical embolism. Uh, I'm sure you can form your own decisions along the line. And then there's always a debate as to which ASDs should be closed surgically or with device. So initially, it was only the secondum ASDs that were being closed with devices. And as people got better and better skilled at doing that, they now started attempting to close other forms of ASDs, especially the sinus venosus one. It's quite debatable. The older cardiologists feel like you should leave sinus venosus for the surgeons. The younger ambitious ones feel they can close it. So there's always that argument when you go for conferences. And then PFO closure has become, like I said, an ish thing all over the world. People are trying to close it all the time, but there are pros and cons to it. Okay, so it's just something that I feel like as an adult cardiologist, you need to know about and be able to defend your stand. So we'll move quickly to ventricular septal defect. I'm not sure I'm doing with time. And okay, so they are left right shunt lesion at the ventricular level, and then no, this is erroneous. This is a typographical error, so ignore it. But the important thing is that it constitutes about 20% of overall congenital heart defects. So this is also a left right shunt lesion, but more importantly, is the left atrium and left ventricle that are dilated. So in ASD, atrial shunt is the right side that is dilated. In VSD, also a left to right heart shunt is the left side that is dilated. So this is something that sometimes gets confused and people are unable to explain it. But we can appreciate that the ASD, all the volume to the right atrium, all the volume comes down to the right ventricle and then up into the pulmonary artery. But in VSD, the blood crosses from the left ventricle straight up into the right ventricular flow tract into the pulmonary artery. Okay, and then that blood quickly returns back to the left atrium. So that explains why you have the left side being dilated. The shunt is also dependent on the size of the defect and also the pulmonary vascular resistance and the systemic vascular resistance. The shunt in this place is greatest in ventricular systole. And just like we have with ASDs, there's a lot of remodeling leading to increased pulmonary vascular resistance, pulmonary hypertension. And so ultimately in the child, they fail to thrive as they get into heart failure. As they get older, they move into pulmonary hypertension, and then much older into Heisenberg syndrome. So this is what we are talking about in a simple term, the defect. So, like I said, you can see from here, blood from the left ventricle through the defect and then straight up. It doesn't linger in the right ventricle because sometimes people feel, oh, left to right, so the right ventricle must also be dilated. No, it just goes straight up here. There are various types, like with the ASD. There's the inlet component, which, if you remember from the embryology, around the endocardial cushions. Okay, that's the inlet one. Just when you go beyond the insertion of the tricuspid valve, you see that's where you see the inlet component. And the muscular one, which usually happens in multiple forms, which they tend to call a Swiss cheese. That's like a cheese with a lot of perforations in it. Okay, so that's the muscular one. And the perimembranous ones, okay, around the membranous septum, and usually they are associated with discrete subaortic membrane and subaortic stenosis. And then the outlet ones, which usually occur during the septation of the truncus arteriosus. I mentioned that yesterday as well. Okay, and they are associated with chondrotruncal abnormalities and then associated with severe aortic regurgitation. So each of these VSDs have associations that are important when you are doing an echo. Sorry about that. So the inlet one, once you find an inlet VSD, you must go and look at the anterior mitral valve leaflet to make sure that there are no clefts in it. A muscular one, if you see one, you must look for the others. Okay, it's seldom do you have just one muscular VSD. The perimembranous ones will tend to have discrete subaortic membranes as well, which causes subaortic stenosis. They must be identified so that during surgical closure, the surgeon can either excise the membrane or incorporate it into the closure of the defect. And so, in I think last 2 months, we've had maybe 2 patients who have come back after VSD, perimembranous VSD closures. The subaortic membrane was not taken off, and now they have subaortic stenosis. And then you know that once you have subaortic stenosis, the jet uh, erode on the aortic valve itself, and then you end up with aortic regurgitation. So it's important to identify this on echo. And then the outlet ones are usually associated with either tetralogy of Fallot, truncus arteriosus, interrupted aortic arch, hypoplastic left heart syndromes. So once you see an outlet VSD, you need to pay attention to the aorta and the pulmonary artery. There are common genetic associations, George, which I talked about yesterday. So every VSD patient must be assessed from a syndromic point of view. Down syndrome, Edwards syndrome, Patel syndrome, Noonan's, and then also infants of a diabetic mothers, they tend to have VSDs as well. So that's something to also bear in mind. Which is why pre-gestation mothers who have diabetes need to be controlled properly before they get pregnant so that they don't end up with babies with VSDs. So from a history point of view, once again, depending on the size, the patient may be asymptomatic. Small VSDs usually asymptomatic, but the bigger they get, the more you see the symptoms of heart failure, and the symptoms of heart failure are age dependent. So in an infant, they'll fail to thrive, they'll have the cardinal tachycardia, tachypnea, hepatomegaly. Okay, but as you get older, then you have your exercise intolerance, your uh, autopnias, your pedal swellings as well. You seldom have pedal swelling in children, but then as you get older, you get those other symptoms. If it goes uncorrected, then you have symptoms that suggest pulmonary hypertension. There's supposed to be a space in between here. It's ironic initial improvement. So usually when we find out in our children a lot, they start out with heart failure from the VSD. As they get pulmonary hypertension, the heart failure symptoms disappear. And so they become very fine. And that's when the parents decide not to bring them to the hospital again because they feel like, oh, they are no longer coughing, they are no longer having chest infections, they are putting on a bit of weight, so they think that is fine. They don't come again. But then soon the pulmonary pressures become more than the systemic pressures, and then they begin to show signs of as pulmonary hypertension ischemia. So this ironic initial improvement is something that we find a lot in the pediatric age group. So physical examination as well, they may be normal earlier on. They may show signs of inflammatory from the failure to thrive. They usually well saturated, but then as they get more and more features of heart failure, we begin to see the increased precordial activity, displays apex, the characteristic pan-systolic or polysystolic murmur, and then they may have an ejection systolic murmur in very large, unrestricted VSs where you don't hear the systolic, holosystolic murmur, but instead you hear the ejection systolic murmur from the rush of blood across the pulmonary valve. And then the mid-diastolic murmur also at the apex, which is because of the rush of blood from the pulmonary veins across the mitral valve. So once they get into pulmonary hypertension, ischemia, then we begin to see features that suggest that there's some flow reversal or the right side is failing. So they are sinus, right ventricular heave, epigastric pulsation, loud P2s. The murmurs get softer and softer, and then ultimately they may disappear at some point. So the chest X-ray also dependent on the shunt. You may have a normal cardiac side with normal pulmonary vasculature, but then you can soon move from a cardiomegaly, left atrial dilatation, plethoric lung fields, and then if you begin to see signs of heart failure, the heart returns to a normal size. The pulmonary arteries are dilated with proning. So this is what you typically will see: a dilated heart, plethoric lung fields. Okay, with and then when it gets even more worse, you can see the very plethoric lung fields, the pulmonary dilatation as you see here, the splaying of the carina as you see in left atrial dilatation. So ECG may have normal findings, but when you have a left axis deviation in a suspected VSD, think about an inlet VSD. Okay, so inlet AVSD type. So if left axis deviation, left bundle brown block, repeated. And then if it's a right, if you see a right axis deviation, right ventricular hypertrophy, right bundle brown block, then you think of pulmonary hypertension in association with the VSD. So on echo, once again, we try and define the location of the VSD, the size and the hemodynamic effect and the associated lesions. So the various echo views will define specific types of VSD. So the subcostal and parasternal long axis will help with the perimembranous type. The apical 4 will help with the muscular. The apical 4 also helps with the inlet. But then when it comes to outlet, it's either the subcostal or the parasternal long and short axis. So I have a few images to show. I'm hoping that this plays. Okay, so this would be a typical perimembranous subaortic VSD. So you see that this VSD here, and then this is the aortic valve right in its way. Okay, with a lot of tricuspid valve tissue floating within it. Okay, all right. So, but this VSD is not a usual VSD in the sense that you can see that it is shunting blue away. So shunting from right straight into the pulmonary artery. You can see that the septum is a bit displaced, and then the aorta is overriding it. So this is the kind of a VSD that you see in tetralogy of Fallot. Okay, so right ventricular hypertrophy. Okay, a sub-aortic or subarterial VSD overriding a ventricular septum, and the shunt, like I said, is a right to left shunt going straight up in the center of the heart, and then we can see this VSD. What you can see is that the margins of the VSD are in close proximity with that of the pulmonary valve. So once again, this is a typical perimembranous subarterial, or some would say doubly committed or subpulmonary VSD. Okay, so this is a parasternal long axis view. Okay, and then we can also see another VSD in the parasternal long axis view. Okay, the left atrium, left ventricle, and then left ventricular outflow tract, and then the VSD that is in close proximity with the aortic valve. So these are the kind of VSDs that can lead to a prolapse of the non-coronary or right coronary cusp into the VSD and cause severe AR. And then this is a patient who came to us with severe hypertrophy with the district subaortic membrane and causing severe left ventricular outflow tract obstruction. You can appreciate the severity of the hypertrophy. But then during his follow-up visit in the epical 4, we noticed that in addition he has a mid-muscular VSD, which you can see over there. Okay. And muscular VSDs are the ones that can easily be missed, especially when you have a hypertrophied muscles like these ones. Okay. All right. So let's see. And then let's see which kind of VSD we have here. Okay, so this is a typical perimembranous VSD. This one is shunting, okay, left to right. So what is the role of CAT? Once again, hemodynamic studies. So QPQs of 1.5 indicate that the significant shunt and the VSD should be closed. You can also assess for pulmonary hypertension and reversibility. Also, you can also define associated lesions, whether they are truncal abnormalities. And then during cardiac cath, we can also do device closures as well. The other investigations that may be warranted, but that's if your ultrasound doesn't give you all the information you want. Genetic studies, this should also have been with the ASDs as well, have become very, very important because of the management of comorbid structures. Okay, Down syndrome, George, Noonan's, they all have systemic implications for the patient, and so the focus should not just be on the defects. So treatment, you can do watchful waiting for the small ones. A lot of them close spontaneously. Medical management, which will include treating antifailure or pulmonary hypertension, surgical closure with patches or device closure. Post VSD closure, once again, just as you have atrial tachyarrhythmias with ASD closures, they have a lifelong risk of complete heart block. So in the past 3 weeks, we've had 2 patients who've come back post VSD closure with complete heart block and are being worked up for pacemaker insertion. Okay, so they have to be followed up for life. Okay, so these patients will come to your doorstep. And then even for device closure as well, this is one of the dreaded things with device. So it's one of the controversies as well. Just as we had the controversies with the ASD, the controversy with VSD is that should we close all VSDs with devices? Because the devices tend to erode into the bundle branches. Okay, and they end up with, and then also superiorly, and then end up with complete heart blocks, especially the devices that are used to close the perimembranous VSDs. So some people say that just use the devices to close the muscular VSDs because they are a bit further away from the bundle of His and the AV node and the early portions of the bundle branches. So if you like the muscular region is a bit safe for devices. So that's the compromise for now. But then there are other schools of thought who think that no, all VSDs must be closed surgically. Okay, but as you can see, either way, the risk of complete heart block still remains. So you must decide where you stand and then defend it. Okay. So with that, I'll end the first portion of this. And if there are any questions, I'm happy to take it.
Thank you very much. Thank you very much, Dr. Elijah. Wonderful presentation. We are so grateful. So, I'll start with a question whilst colleagues also bring in their question. With respect to the device therapy, can you emphasize in terms of the size that is considered relevant for device closure and the size that is contraindicated for the purposes of vivas and discussions in case they meet such a case. And to note, for in the April, one of the station was an ostium primum ASD with dilated right-sided chambers. The discussion led to more Izemenga and the management. So it's a very examinable area, and you won't get all these color Doppler he showed. It was a still image, black and white. There was no color with distortion of the anatomy. So you need to take notes of these anomalies and how they present and how to identify them under tension. Thank you very much.
Yes. Okay. So thank you so much for the question. So the usually we try to close small to moderate size VSDs. Okay. So you are looking at uh, if you have a VSD that is less than 4, you're not even bothered about it. So 4 to about 8. But the key thing with the closure is not so much at the size, but the amount of rim you have available. So the closer the margins of the VSD are to the insertion of the atrioventricular valves, the less likely that you are going to try and close it with the device. Because if it gets so closer, then the device hasn't got any superior area to rest upon. Okay, so let me use the okay, so let me use this one as an example. If you are going to put a device, for instance, in this one, the device is going to stretch from here to about here. If there's no tissue here for the device to rest on, then even if the defect is small enough, let's say a 5 millimeter, you're not going to put a device there. So device insertion small to moderate, but there must be adequate rims around it for the device to sit upon.
Thank you. Dr. Zhaba, the ASD. Some references have said a cutoff of 4 centimeters for device
Mm,
closure. Some have said 3.5. What is your opinion on that? And with respect to your experience with device closures, what usually is your cutoff? In that noting, so this is an ASD with good rims. So we are
yes.
talking with to size.
Okay, so you are perfectly right with the numbers that you're talking about. Some people talk about 3 to 4. That you can go up to 3. Some people stop at 3. Some people go stop at 3.5. Okay, we have tended to go up to 3, uh, but it all depends on the experience of the interventionist. Okay, so far we tend to go up to 3. Beyond that, we'll give it to the surgeons to close.
Thank you very much. Please, let's go. So there's a question. Do we also do agitated saline contrast by echo in ASD currently?
Yes, we do. We've done quite a number recently because the older the patients get into adulthood, their windows get poorer, and then unfortunately the atrial septum becomes difficult to outline. So there have been a few times where adult colleagues have, or other from external, have referred patients to us for a second opinion, And then we've done the agitated saline to establish that indeed there were atrial complications or there were no atrial complications. So yes, we still do agitated saline.
Good evening, sir. Thank you for the very lucid presentation. I just want to ask that can a patient with ASD or VSD
I
that
hope you
have
are fully awake. That
very
was one of the
high
concerns of our
pulmonary hypertension?
facilitator and presenter. Let's make sure we are awake because I told you we were going to be awake. And we need to show that by asking questions and clarifying concepts and thoughts.
Can I go ahead, sir?
Hello, Gordon. Chineme, Cassidy,
Yes,
Bose,
awake,
Dr. Sally,
awake.
Nwako.
Hello, good evening.
Are we on?
Good evening, Eugene. We are on.
Can I go ahead, sir?
Hello.
Hello, Eugene. We are on.
Hello.
We're on. Somebody is asking a question, sir.
Can I go ahead, sir?
It's not hearing us. So.
Good evening, sir. Thank you for the very lucid presentation. So I just wanted to ask for surgical treatment of patients with ASD and VSD. If they have increased level of pulmonary hypertension, can it be up to a particular level that will make you think that you don't want to go ahead to give that kind of patient a surgical approach? And then when we get to that point, will the patient be kind of restricted to the maybe medical therapy as the only option that they have? And the usual cutoff level for pulmonary hypertension that you think you might not want to work with to operate on. Thank you, sir. Then, secondly, I think from yesterday, just to throw a little more light on I think it should be around the cardiac looping, where the outlet, some of them could have a double outlet. I'm not sure now. I think it's for the right ventricular outflow tract having a double outlet. Just to make some comments on that. Thank you, sir.
What's the volume?
Hello.
Yeah, hello. Sorry,
Yeah.
I dropped off a bit. My
Can you ask your question again? Dr. Josie dropped off a bit, so if you can ask your question again, please.
Okay. Thank you, sir, once again for the very lucid and helpful presentation to understand the process better. So my question one is that for you to go ahead with your ASD surgeries and your VSD surgeries closure, are there particular venous pressure that you would make up your mind and say, we want to go ahead with this, and at what level would that be that you wouldn't want to go ahead? And just to make a comment to one of the presentations we had yesterday, where you were talking about the cardiac looping, I think around that point, going forward with the septation, I'm looking at explanation of someone that will have a double outlet for those that may develop a double outlet, just to explain whatever gets wrong in that pathway that makes them susceptible to having a double outlet around the truncus arteriosus area, maybe for the pulmonary or I think aorta. Thank you, sir.
if I understood the question, the first question, if I understand, is what are you assessing to decide whether this VSD should be closed or not? So I think in the presentation I did mention that one of the key things you try and assess is the PVR SVR ratio, and as if it's more than 1.5, that means you have a significant shunt that can be closed. If you have PVR SVRs that are less than 0.7, either the shunt is not significant or you have established pulmonary hypertension. And then once you have that, especially if your PVRs are in like more than 3 or 5 Woods per unit, then you go and do a reversibility test. Either you're using nitric oxide or, other measures that can be used in the cath lab. Even 100% oxygen as well can be used for a reversibility test. Then you look at the percentage drop in your PVR-SVR ratio or your QPQS or your mean pulmonary artery pressures. And then that will then decide whether you look at ranges about 10 to 20% drops. And then you can decide that if there's no significant drop in those pressures, then the pressures are not reversible. And so then you discontinue any plans towards surgical closure. So just to summarize what I've said, the key parameters are the PVR-SVR ratio. Okay. But then you can also look at just the PVR using your Woods unit, or you look at the mean arterial pressure as well.
So 3 things, sir. The PVR, the shunt ratio, and then the velocity, the pressure.
Yeah, so the mean pulmonary artery pressures, the pulmonary vascular resistance, the PVR-SVR ratios, those will be the main parameters that we tend to use in the cath lab.
Thank you, sir. Then the second question about those having double outlet, which is an anomaly.
The double outlet. Let me see if I can pull up the image I used, one of the images I used yesterday. Am I sharing? I know.
Yes, sir.
Sorry, let me just do this. I'll share. Okay. Yes. I'll go to the septation of. I think yesterday I was using this to illustrate how the tetralogy of Fallot occurs. So I said that the septation of this is the truncus arteriosus, and this is the primitive ventricle. And I said that the right and left ventricle are septated straight up, down up. And then I said that the truncus arteriosus is also septated in a spiral manner between divided into the aorta and then the pulmonary artery. So then I said that if the spiral septum that divides the truncus arteriosus does not align with the interventricular septum, then you can have various degrees of conotruncal abnormality. So the example I have here is that if the spiral septum septates unequally, and this time the septum moves anterior because the pulmonary artery is an anterior structure. So if the septum shifts to the right of the screen, the septum is moving anterior and carphalad. So when it does that, it narrows down the pulmonary artery, and then the aorta becomes dilated. There's malalignment of the septum, so there's a VSD formed here, and then you have this aorta overriding the septum. Now, if there are 2 schools of thoughts about this. If this spiral septum goes further anteriorly, up to about here, okay? If it goes out, instead of being here, it goes here. Okay, let's see if I can use a pen. Okay. It's not going to work, sorry.
You can still follow the explanation, sir.
You can still follow it. Okay, that's good. Okay, let me just continue. okay, gets over here, then you are going to see that the septum is going to be here, and the VSD is going to be much bigger. And so ultimately, the right and the left will then be connected to the aorta. So then you only have a double outlet, okay, right. You end up having a double outlet right ventricle in the sense that you're having a ventricle that is now shunting blood into the pulmonary artery in a small manner, but a significant portion of it is shunting most of its blood into the aorta. So that is what distinguishes tetralogy of Fallot from Dove. The difference is the extent of the override from a clinical point of view. So if you have an override that is about 50% overriding of the aorta, so then you have a tetralogy of Fallot. But when you start having overrides that are above 60%, then you have a double outlet right ventricle. So that is one of the simplest way of looking at it. But the embryologists the embryologists also have another consideration in that embryologists feel that it's not just about the septum alone. To pick up another, okay, they think that the problem is not just about the extent of the septation, but then they also feel that sorry, I think my thing dropped off again. So they feel that if you have the truncus, the cushion here forms in such a way that the mitral valve and the aortic valve, the anterior mitral valve leaflet, which forms from this cushion, and the aortic valve, the left cusp, which forms from this tissue, they must be in continuity because they are so close to each other. So when this valve forms and this valve forms, they must be close to each other. But when you have a fibrous tissue still remaining between the anterior mitral leaflet, which forms from this, and the aortic valve over here, and this whole place persists, the persistence of that fibrous tissue causes a discontinuity between the mitral valve and the aortic valve. And for some people, especially the embryologists, that is the definition of a double outlet right ventricle. Okay. So from a functional point of view, it depends on the extent of the override. But from an embryology point of view, it is defined as a fibrous discontinuity between the aortic valve leaflet and the anterior mitral valve leaflet. I hope that explains it.
Thank you, sir. It does.
Yes.
Thank you very much. Do you have any question again? Can I be heard, please?
Yes, I can hear you.
Okay, so we've taken Dr. Dele's time already. So in the absence of any further questions, we want to say a very big thank you to him for making time to do this wonderful presentation. Like Oliver Twist, we'll ask for more for him to finish up. We'll see him on the side and see how best he can help us out. We know he's very tight, but we are very grateful once again. Thank you, Dr. Deladosi, for this wonderful presentation.
Thank you so much as well. Apologies for the co-presenters in the background. That's what happens when you are presenting from home. Your kids don't allow you. But I hope it didn't disrupt anything too much. And then I look forward
Not
to
at all. Not at all.
Yes. All right. Okay. So I wish you all the best, and yeah, hopefully we meet soon. Yeah. Have a good night.
Same to you, sir. Thank you very much. Gordon, over to you.
Okay. Thank you very much, Eugene. Thank you very much, Dr. Dela, for such a wonderful presentation. Things are becoming clearer with time. We are very grateful. Is any of our facilitators, consultants on call? I'm not seeing any. Okay. Please, Dr. Adeyanju, please, your audience.
Hello, good evening, everyone.
Good evening.
Please, am I audible?
Yes, please.
I'm sorry I joined late. I've been busy, but I'm very sure that we are taking a day at a time and we are pushing ourselves to achieve our aims and goals. I wasn't able to join the presentation, but just like what Dr. Dela presented, I know that he must have presented it well. And I want to tell us that there are a lot of MCQ questions that comes from the aspect he has presented. They bring pictures out. They still use agitated saline, as has been said, especially in low resource. They do a lot of that. So they can bring either of the pictures in the MCQ or in the OSCE and ask us to talk on it for the line of management. So I want us to take note of that. Otherwise, I wish all of us a pleasant night rest. Thank you very much for the opportunity.
Thank you very much, boss, for the additions. We are very grateful. Please, any questions, additions? Dr. Eugene.
Thank you very much. Just for emphasis on the indications for surgery, remember the pulmonary artery systolic pressure cutoffs. If preferably wants your pressures to be less than the vascular resistance to be less than 3 Wood units, and if it's greater than 5, as much as possible, surgical intervention or closure is contraindicated unless you can get it below 5 with medications. And also remember that sometimes they use 2/3 of the systolic pressure. So if your pulmonary artery systolic pressure is greater than 2/3 of your systolic pressure, then that is also a contraindication for closure. Preferably you want it less than 1/3 or 1/3 to 2/3. So we should know some of these things because, like I said, we had an ostium primum ASD with dilated right-sided chambers and features suggestive of Eisenmenger, but it was a still image picture, black and white, no color. And you have to understand that and correlate with the ECG and the management. So as you describe the findings, then the questions follow and you move along. So if you miss the ostium primum ASD and notice that it's a left to right shunt and currently there's the possibility of reversal, you may not be able to discuss that point. So please, this embryology and discussion that Dr. Dela did is very relevant. And so let's take note of that. Let's look at the pictures, how they look like, so that you have an idea, because ours, the anatomy was distorted because the right was markedly dilated. So it was literally, it was an apical chamber, but it was literally like a reverse parasternal lung as it sort of, because the RV was dilated, forming the apex and lying on top of the LVs, which was squashed. And the RV was also squashed. So if your anatomy is not clear, you may miss it. So please, this is very relevant. And let's look at more images and read around it. Thank you very much.
Thank you very much, Dr. Eugene. Please, in the absence of any more contributions, we want to end here and then continue tomorrow. Tomorrow we have a guideline presentation on atrial fibrillation management. So we'll meet tomorrow, and the time is 7 p.m. Oh, is it 6 p.m., brother? Okay, I'll confirm the time and put it on the page. Okay, thank you. So have a good night, everyone.